Hello, and welcome to the HealthMe Asia podcast. I'm John Linebaugh, and I'm your host. As the name of the podcast implies, we'll be looking at some unique and interesting healthcare services available in Asia and showcase their quality and their value. We're at Bangkok International Hospital in Bangkok, Thailand. This hospital is one of the premier hospitals in Thailand and is home to many young and dynamic doctors who are leading the way in world-class healthcare delivery. On this episode, we'll be meeting one of the best hip replacement surgeons in Asia, as well as a talented internal medicine physician who takes care of patients after their hip surgery. Let's meet these rock stars. Here on the show today is our guest, Dr. Paul Phonthakorn. So, welcome to the show, Dr. Phonthakorn. It's a pleasure to have you here. How are you doing today?
Very good, sir. How are you, John?
I'm doing good, thanks. I want to ask you to tell us about yourself and your background and how you got started as a hip surgeon.
Yes, I am the orthopedic surgeon. I specialize for the hip and knee replacement, and I was trained in US and Canada for 3 years. I studied at the Mayo Clinic, Rochester, Minnesota, and Anderson Clinic in Virginia. And lastly is in London, Ontario, for 3 years totally. And I'm your surgeon.
Oh, yeah, that's right. How many years have you been, practicing as a hip surgeon?
So I practiced for like 15 years already with the old technique for 5 years. And I convert from the old technique to the new technique for 10 years. So total time is around 10 years with the hip replacement around more than 1,000 hip replacement.
I was going to ask you how many. Can you tell us how many?
More than 1,000.
More than
already.
1,000.
Yeah.
Roughly, how many of those were foreigners? Do you know?
I think 50% of the foreigner. Yeah, like 70% of foreigners come from the expat in Thailand. Another 30% come from all around the world. We have the patient from US as well, Canada, Cambodia, Myanmar, Singapore, all around the country in Asia. They can come here and have the surgery with us.
Let's talk a little bit about, hip surgery. How do you identify that somebody needs to have hip surgery, and what are some of the most common symptoms or signs that you see?
Yeah, it's quite easy. When we can see the patient like walking to our clinic, and then after observe he's walking, and we can see that there's a limping a little bit, and we think that this is maybe the hip disease or the knee disease. And normally the patient have the symptom mostly come from the groin.
Yeah.
So when they have a groin pain, so it is mostly from the hip disease.
Right.
Yeah. Sometimes they have a back pain as well, but it's not common for the hip disease.
Okay.
Mostly the hip disease come with the groin pain.
So then from that, obviously, then you send them for other diagnostics, X-ray, MRI.
Yeah, for sure. When we do the examination, we feel that when the patient have a stiff hip, we have to do the X-ray for sure. 90% we can diagnose with the just with the X-ray. There's no need to do the MRI.
And MRI is not.
But some patient like 10%, we need to do the MRI to check what is the cause of the pain. Yeah.
So then help us understand the difference of what you get from the MRI versus the X-ray in your decision.
Yeah, the X-ray we can see only the bone, okay, but we cannot see the soft tissue. But with the MRI we can see the soft tissue. What does soft tissue mean? The soft tissue is that the hip joint, there's a combination between the hard bone and also the cartilage. So with the X-ray, we cannot see the cartilage. We see only the bone. So when the patient have the arthritis of the hip, with like the advanced state, we can see the bone on bone. We can give diagnosis from the X-ray. But if the patient has a very early arthritis, we cannot see from the X-ray. So the X-ray shows nothing. So we have to do the MRI. The MRI can show us more detail of the cartilage or the soft tissue.
And if they have, the cartilage would look, you would see tears or damage, or
we can see everything from
to the
MRI.
structure.
Yeah,
right.
That's right.
And that would be what you use to say, we need to replace a hip. So then what are some of the treatment options at that point besides a hip surgery? And I'm not trying to take away from what you do, but what could be some alternatives?
Yeah, for sure. The hip replacement will be the last option.
Okay.
Yeah, the first one we have to start with the medication. and also the activity modification. Let's say try to reduce some weight, try to avoid some impact sport. This is the first step for the treatment. And after the medication and motivation of the modification of the activities, so we recommend to do the hip injection. We call the ultrasound guide hip injection.
Is that where they actually traction and kind of pull it apart a little bit, or is it?
So there's two things that we can offer to the patient for the hip injection. The first one is cortisone. The cortisone shot, the cortisone, the steroid.
Yeah.
So it give us the good pain relief, but it's do nothing with the movement. Another one is what we call the HA, or hyaluronic acid, or the gel injection. That gel injection can help the patient to
have space.
Yeah, space, right? And
create
better
space.
movement. It's like a lubricate the joint.
How long has that been a treatment option, the hyaluronic acid injection?
So it depends. So some patient, the gel can last long for 6 months.
Okay.
The procedure is take like 15 minutes, like with the ultrasound guide. But it's worth for the patient to do this thing as well, because most of the patient, they don't want to do the surgery, right? No patient want to do the surgery, but with this one can give them the better quality of life for 6 months.
That's an interesting point.
Yeah.
Because I'm going to confess now that I had hip replacement surgery.
Yeah.
And I didn't want to accept that I needed it because I thought it was going to have such an adverse effect on my life as an active, sporting, person.
Yeah.
And so I want to talk about that a little bit with you, because I see what you mean. If they have this time now to digest that, they're gonna. It's a better option, right?
Sure.
If they need to have the surgery.
Yeah, I agree. Yeah.
So then, what are some things that do you talk with patients about that sort of acceptance or that journey, or do you say up to you? Is it kind of like that?
So I think the key person to decide when they're ready for the surgery or they need a surgery is the patient themselves, because if they have a very bad quality of life, this is the key that they need to do the surgery. If they cannot walk for like 100 meters, they cannot go for shopping, they cannot traveling. So this is the key point that, okay, maybe we need to do the hip replacement. It's not the surgeon, it's not the X-ray, it's not the MRI, because the key is the quality of life of the patient.
Yeah.
Some patients have a very bad X-ray, but if they can live with it, so that's why we have to offer them the hip replacement, right? So the patient decide by themselves that doctor, I need to do the hip replacement. They can come to consult for consultation, have the X-ray, full scan, and it just let when you're ready for the surgery, just call us, just make the appointment, and we can go ahead with the surgery.
Another good point, because my quality of life, once I got to this point where it was accepting that a hip replacement was what I should do, it was horrible as far as, traveling on airplanes and sitting.
That's right.
And ironically, the time that it hurt the most was when I laid down in bed at night. Yeah. And I guess that's where the contact of the bone and nerves and stuff like that. So there was an observation, or I don't know if it's diagnosis is the right word, but an observation that you made based on the lesions on my femoral head and the size of those lesions.
Yeah, sure.
Can you?
Yeah, so
not mine necessarily, but can you talk about that?
Yeah, so the lesion is one of the indication. If they have the very big lesion, we tend to go ahead with the surgery, because with the big lesion, the conservative treatment, let's say medication, modify activities, cannot help for sure. And this group of the patient, they need more the surgery. But with the small lesion, some patients, they still need the surgery as well. Not because of the small lesion, but because the tolerance of the pain level is different. Yeah. Some patients have a very high tolerance for the pain level. Even the big lesion, they don't want to do the surgery yet. But with some patients, they have a very small low threshold, right? So even the small lesion will affect quality of life, and so they decide to do the surgery with the small lesion. Yeah.
Another piece of advice that I remember was that if I decided not to do the surgery, I could live with the pain and medications to try to help. But I also remember facing the prospect of a collapse.
Yep.
And then it's an emergency.
Yep.
So
it's procedure. If they have a fracture, some patients have a some disease that we call the osteonecrosis of the hip. It's not the arthritis. Some part of the arthritis, but inside the hip joint, there's a dead bone.
Okay.
When they have a dead bone, if they have small lesion, there's no collapse or the fracture yet.
Yeah.
But at that point, at that day, if the head of femur is collapsed or the fracture, is create a very big pain, huge pain. So they will come to the hospital and doctor, I want to do the surgery next day, next 2 days.
It's emergency.
It's more, it's urgency.
Yeah. But are there some potential issues to other structural damage from that if they wait? In other words, like if there is a collapse, is there from your side of like getting in there and cleaning and making sure everything, is there concerns or issues with that?
No. Because with the hip replacement, there's not quite emergency. We can wait for a couple of days, one or 2 weeks. That's enough for the surgery. But there's no need to rush to do the surgery. We have to wait until the patient is ready for the surgery. Once it's ready, the body have to be ready, and the checkup should be passed.
Pre-surgical screening.
Yeah, it's very important. If we go rush to the surgery with the emergency condition, is not quite good for the patient as well. So we can wait for 1 or 2 days. But at that time, the patient is so painful.
They want immediate relief.
Yeah, that's right.
Right.
Yeah.
So you give them medications.
Yeah, IV.
Or an IV injection or something. Yeah. Okay. So what I want to do now is talk a little bit about you're going to do the surgery. So what are some considerations you make as you decide we're going to do, the anterior approach, I think is what you champion. Can you talk a little bit about the anterior approach and why?
And why? Yeah. So in the past, I think most of the doctors in the world, we were trained with the posterior approach or the backside. And when we do the hip replacement with the posterior approach, it's what we call the standard procedure right now. It creates some problem. The first one is the dislocation. So the hip can dislocate. So after the surgery, we cannot let the patient sit like you and me here, because it creates a high chance of dislocation. The hip can pop out
because of cutting muscle.
That's correct. Because we have to sacrifice some muscle, and the stability of the hip is not quite good. And at the end, sometimes we end up with the longer leg. Because we want more tension. So we let the patient, we lengthen their leg a little bit. So walking is not quite normal because the leg is too long. So this is the problem with the posterior approach. And it's good for a while because the authority in the world, they use the posterior approach for several years, 50 years, 90 years, almost 100 years as well.
Is that what you learn in school?
Yeah, we learn. And most of the surgeon learn from this technique. But when I train in Canada and USA, I get some new technique that we call the anterior approach or the DAA, direct anterior approach.
Yes.
So we go through the hip joint from the front at the groin area, the groin case here. The key is there's no muscle cutting. So
is it just moving?
Just move the muscle.
Right.
But there's an interval between two muscles.
Okay.
So we have some instrument tools to move a little bit, and we have the space to put the hip replacement down there. So when we do the hip replacement via this portal or the direct anterior approach, there's no muscle cutting. At the end, the patient has no pain or less pain than the posterior approach. The stability is good one. So the patient have they can do every position. They can sit on the floor, especially Asian people. They can do cross leg sitting here. There's no precaution after the surgery, and the recovery is so fast. So they can walk the day of the surgery. In US, they can do 1 day surgery.
Right.
Surgery in the morning.
Same day
surgery. We can do it here as well. But it depends on the health of the patient.
Their recovery.
Right? Yeah.
So, as we were talking earlier, I can attest to being on a trampoline in a trampoline gym. I think it was maybe not a month, but maybe 6 weeks post-op.
You sent me the video. I remember.
Right. And
that's crazy. That's good. Man.
I came to see you at follow-up, and I showed you myself jumping.
Yeah. You can see the recovery is amazing. You can go back for sport within a couple of weeks after the surgery. This trampoline is more advanced, impact sport, right? But with the swimming, walking, jogging, golfing, you can go back with this type of sport within a couple of weeks after the surgery with the direct anterior approach.
I will also say that obviously I had pain medications IV in the hospital for my few days
Yep.
After the surgery. But on discharge, I was given, like oxycodone, like a Ultraset.
Yeah, oral one.
Right. And I never took it.
Oh, really?
Never
Wow,
took
that's
it.
a good one.
I know, right? And it wasn't because I felt like I'm so strong or anything.
Yeah.
I just was like, the pain was never to a level that I felt like I needed to take that Ultraset.
Yeah, most of the patient is the same. Like they why doctor give me the medicine? I have no pain. The pain that you have before the operation is
worse.
It's worse than after the operation. This is the key of the benefits of the direct anterior approach, because when you cut no muscle, so it's like a no pain. It's like less pain than the conventional technique.
I want to talk a little bit about leg length.
Leg length, yeah.
And I don't know if you will remember this, but
Yeah.
I do, and I always enjoyed thinking about it. I had a little bit of curvature in my spine on the X-ray or the CT scan because I was compensating.
Yeah.
As you said, most people have a slight differentiation
Sure.
in their leg length.
Sure.
And I remember you said, we have to have this conversation.
Sure.
Do you want your legs to be the same, or do you want me to correct it? I think that was the word you used.
Yeah. So normally, ideally we want the patient have the exactly the same leg length, but sometimes the patient come with the curvature of the spine because of compensation. So because you have normally when you have the bone-on-bone arthritis, right? Normally that leg should be shorter, but with the compensation, the body try to tilt a little bit.
Take the pressure.
The pressure. So at the end, come to the hospital and see the doctor. The leg length that's not different, right? Because they tilt a little bit. So after the surgery, the key is we have to restore the leg length back to the normal stage before before the arthritis happen. So at the end, after the surgery, some patients they feel that the leg length is longer than normal, like for couple months, and you have to train your brain how to walk again with the normal length. Right, so normally take a couple months until you feel the same length. But we have the X-ray or some navigation that we can control the leg length during operation.
Okay.
So we're 100% sure that this patient have the perfect leg length during operation. But after the operation, some patients they feel that this is longer.
Yeah.
Because they walk with short leg for a long
time.
And the brain is remember this position, like okay, this is try to compensate it. This is the problem. So we have to have a good conversation with the patient to address this problem, this issue before the operation.
And I don't know if you remember this, it's been 5 years, I believe, right?
Yeah.
But I asked you to correct it, to make, because I had a little bit of hip, they were slightly
Tilting, right?
tilted.
Yeah.
And I remember saying, I want you to make them even,
Yeah.
Because I had always suspected that part of my back
Sure.
aching and stuff was not just the arthritis, but my compensation.
It affects all of your body.
Yeah.
When you have a good correct of the leg length after the operation, your back tilting will back to normal. And at the end, you have a less chance of the back problem. If you walk with a shortening leg for a long term or longer leg with after the hip replacement in some technique, it affects the back as well. Because the leg length there's a big difference. So you walk and you tilting a lot. So it's not good. So the key benefit is the leg length with the direct anterior approach that we can guarantee that the leg length should be equal.
Okay.
Yeah.
I chose for them to be equal, I think. And I still feel happy that I made that choice. And I remember asking you, is it wrong for me? And you said, no, it's just, we need to know. And I did notice a little bit of, it felt like that foot was sticking out more or longer, the proprioception, I guess, right?
Yeah.
But as you said, eventually it disappears and you would never know.
Yeah, because your brain learn how to walk with the new hip.
Right.
So they compensate everything back to normal. Right now, I think your leg length should be the normal stage before the arthritis stage. Yeah.
So if you have let's say you have a hip replaced on the right side, statistically or from your experience, how many patients end up needing another hip replacement in their lifetime?
Yeah, so 20%, I think.
Okay.
So not every patient has to do the bilateral hip replacement.
Okay.
Yeah, some patients, they have bilateral diseases, like one hip arthritis and another hip arthritis because they're overweight or the genetic something. Or some patients, they have the traumatic arthritis. Normally, this group of the patient, we have only one hip replacement.
Okay.
Like this morning, we did one patient that have arthritis on the right side, And next 2 years, I think he come to the hospital and ask for another surgery for the left side. So around 20% of the patient that needs to do the hip replacement both sides. Yeah.
Okay, so what we're going to talk a little bit now is, after surgery, what's the usual plan for the patient?
Mm-hmm. The patient has to walk for sure. We let the patient walk the day of the surgery. We do the surgery in the morning time mostly, and then in the afternoon time, we have the team to let the patient walk by himself. And walking within the same day is very, very important point, because the patient feel that they feel more confidence after the surgery, because most painful thing, most bad thing for the patient, they are afraid to do the operation because they don't have that confidence to walk. Can I walk after the surgery? Most of the patient, they think that, I cannot walk after the surgery. But when we do the surgery in the morning time and we let the patient walk again at the same day, they feel like, I can't walk. So at the end, for the recovery, they have better recovery than the patient that have a bad mindset that I cannot walk or something.
That's a great point. And I never thought about that until you said that, because I got up, you guys had me in walking on the ward, helping but I didn't realize the dynamic that it has on your psychology.
Sure, it's very important.
Because most people view a hip, it's the largest joint in your body.
Yeah, very, very important joint.
And so you think it's a huge surgery.
Yeah.
And then you realize, wow, that wasn't bad at all. And I can walk.
And no pain. Yeah, that's one. This is the key point for the recovery, for the whole process.
Right.
Right.
So then obviously coming out of surgery in that good of condition, less invasive, less cutting, the physical therapy part is easier.
Yeah, sure. Yeah, because the recovery is as amazing than the conventional technique. And normally with the old technique, we have to let the patient walk with the walker or the frame for normally 6 weeks after the surgery, because we worry about the muscle that we have to cut and we have to repair. Before. So if we let the patient walk without any support, it creates more further tear after the surgery with the old technique. But with the direct anterior, is you yourself, example like yourself, that you can walk without any support within couple of days, and you can walk without crutches, and so the recovery is much better. And for the physiotherapy itself, when you walk without any support, it's better for everybody, right?
So here's a scenario then. Somebody in the U.S. needs a hip replacement, their insurance or Medicaid, or they don't have it, and there's a gap, and it's expensive, and then maybe their daughter or son sees this on YouTube and social media and says, hey, you can go to Thailand and get a hip replacement there. What are some of the packages and some of the costs that you could talk about?
There's two packages here. The first one is a one hip replacement. The total package around $15,000, including the 5 days stay in the hospital, the surgery and the ICU for one night, and another 4 days for the private room. So we have the team to teach the patient how to walk again. The total physiotherapy time is around 5 days. So after the surgery, they can stay in the hotel, the luxury hotel, and including the total cost, the airfare, the hotel, the surgery, I think it's maybe cheaper than US. I have a lot of patients from US that flew from Texas, from Virginia, come to have the surgery with me here. So you're welcome to Thailand, because the package, I think it saves you a cost as well. And for the two hip replacement at the same time, because of the direct anterior, we can do bilateral hip replacement at the same time, simultaneously. It saves the money for the patient compared with doing the surgery one time and wait for another 3 months and do another one hip. So the total package for the two hips is around $25,000 US dollar or $30,000 US dollar. It depends on the implant that the patient needs to use it. Some patient need a special implant, the premium one. Some patient, they need just really the standard implant.
So then when it comes to the standard and versus premium, what are some of the features or benefits of a premium implant?
So the premium implant, we use the ceramic one. The ceramic bearing, we call the ceramic on polyethylene bearing, is lasts longer than the metal on polyethylene. So it depends on the age of the patient. If the patient come to see me at the age like yourself, 40, 50 years old, I recommend to use the ceramic, which costs more, but it lasts longer than the metal implant. So with the metal implant, we preserve for the patient that have like very old patient, like 80 years old, and we not expect like 30 years lifespan of the hip implant. So we use the metal implant. But if the patient can afford this one, they can use the ceramic. 99% of my patients, they use the ceramic one because they choose the ceramic because it's better. They want the best one. So we recommend to use the ceramic one.
In your estimate or in your experience, what is the lifespan?
So we expect for 20 to 30 years. With the ceramic, we expect 30 years for the lifespan of the hip replacement. So it should be only one operation for their lifetime. So we choose the best one. And with the anterior approach, the premium implant is one of the factor that can affect the lifespan of the implant of the hip replacement. Another one is the technique. When we use the direct anterior approach, we can have a confidence that the position of the implant is absolutely perfect because we have the X-ray and some navigation when compared with the conventional technique. So with the direct anterior, we can put the implant into the perfect position. Yeah.
I'm glad you mentioned that because I was going to ask you that next. Yeah. The orientation of the cup.
Yeah, it's very important.
Yeah, it's like wagging a tail of a dog. If this is wrong, the rest of it is.
No, it will not. The implant lifespan is not quite long if we put everything in the wrong direction. Yeah.
Is it called a cup? I'm sorry.
The cup and the stem. We have two parts, right? The cup, the socket part, and also the stem part. So that's why we call the total hip replacement, the first part and the second part. So the key is the implant. Second one is the position of the implant, and the last one is the patient. The patient activity is also the very, very important factors for the lifespan of the total hip replacement.
Let me ask you, in the surgery, how open do you open up a patient to get the cup in position right?
Yeah. What is it?
I mean, like some surgeries, you have to open them up and put surgical guides and other things to keep them open. Is that?
Yeah. We have to open the hip like normally like 45 minutes.
Okay.
Right. We call it exposure. All right. So there's two types of exposure. We can use the conventional incision, which we call the long-term incision. The second one is a more cosmetic one. We call the bikini.
Yeah.
So bikini incision is a little bit smaller. It's go at the groin area here.
That's what I have.
Yeah, and you cannot, after the completely healing, you cannot see the incision because the healing is so amazing that there's no scar, less scar than the conventional technique. So we call this one the exposure.
Indeed, my scar is hard to see.
Yeah, agree.
It's like sometimes I'm like, is that just me getting old, or it's really hard to see.
Yeah, so the patient has to tell the doctor in the future that I have a hip replacement because the doctor itself they cannot see the scar, they cannot see the incision, they don't know that you have the hip replacement before. So you have to tell the doctor if you have the next examination or something. So the scar is so nice with the bikini direct anterior approach.
Right.
Yeah.
So I want to sort of recap here as we wrap up the value proposition of getting your healthcare in Asia, and a procedure is traditionally viewed as big and invasive as a hip replacement is now actually, as you said, it can be a minimally invasive or a same-day surgical procedure.
Yep. That's right.
And then the cost of the procedure here in Asia or in Thailand, and you guys used all the current advanced equipment and skills and techniques and been trained, many times by those manufacturers.
Yeah.
So that is, again, one of the most important things that I want to convey.
Yeah.
And so thank you for being on the podcast. Thank you for your time. And maybe we can do another episode in the future.
Sure. Thank you so much for having me here today.
Hi, Dr. Jay. Welcome to the podcast. Thank you for being here.
Hello, John. Thank you for having me.
Good. How are you doing?
Good. Thank you.
Good. So we just had Dr. Paul as a guest on the show. He was my hip surgeon, and you took care of me post-surgery. You followed me while I was inpatient. So please tell us a little bit about yourself and why you became a doctor.
Well, I can't say that I remember exactly what went through my mind, like when I went into the medical school, but I can tell you that getting into a medical school is one of the best decision I ever made. Wow. Right. Well, I have so much passion about this career, not only because of the job security, but I feel that feeling of being able to help people feeling better. I think that's a great feeling.
Right. I mean, it's not as you mentioned, job security is one thing, but the fact that you care about being professional and doing a good job for people. So that's definitely admirable. You're a primary care physician and you're also an internal medicine doctor.
Yes.
So I want to understand the not the difference, but how they relate and then the scope of responsibility you have in that role.
Okay. Well, to me, internal medicine is a part of primary care. Well, just to give you a little bit of my background, I finished medical school in Thailand, and then I went to United States for further training. I did my residency and fellowship training in Philadelphia, United States. And then I spent some time working as a primary care in Atlanta for a few years before coming back to Thailand. In Thailand, even now, primary care is not well established here. We have the culture of going to the hospital or going to the doctor when we are sick. So we don't really establish care with the doctor when we're healthy. And I think the concept of primary care is actually a relationship between the doctor and the patient, either when they're sick or when they're healthy. When they're healthy is to maintain their health. We offer vaccination, we offer cancer screening, health screening. And of course, when you don't feel well, when you have issues, you come to us as well. So we're there when you're healthy and we're there when you're sick.
Personalized approach.
Right. So, I think in healthcare or medicine, it's not like one size fits all, So every one of each patient, I think their needs of treatments or screenings or whatever, different in each patient. So what we do is we want to do a personalized healthcare. Like you come to us, we get to know you, and then we can tell you, okay, this is what you need. This is the test that you should do. And this kind of vaccine is what you should do. And even the choice of treatments when you're sick for each single one of patients, also different. Mm-hmm.
So how about, the scope as far as specialties and how do you, what role do you play in that, referrals, et cetera?
Right. So as a primary care, actually, we want to be the point of contact for patient. So no matter what problem you come with, you can come to us. If it's something that we can treat, like we often see like flu-like symptoms, diarrhea, we treat you. If it's something beyond our scope or beyond our expertise, we will do a referral for you. I find it it can be quite confusing for patients, especially for foreigners or expats who move to different countries. Going to a hospital and you don't know where to go or whom to go to or what specialties, what clinics you should go to. So we want to be that person that you come to for any issues. And then we will tell you, okay, this is beyond my scope. I will send you to this and that specialist. And then we can navigate you through the hospital, and, help redirect you where you should go. Mm-hmm.
Because in some instances, a patient walks in and they meet a receptionist.
Exactly.
And so this provides them a more accurate or more
so often
qualified assessment.
Right. Because sometimes you go to this doctor and then you find out, oh, no, actually you have to see a different specialty. And then you get redirected. But having a primary care is pretty much, okay, I evaluate you and then I have some,
opinion.
Yeah, kind of hypothesis, opinion, or, something that I feel like, okay, this is probably your problem. And then I choose the specialist for you.
So how about family medicine or family physicians?
Well, primary care or primary care physician is similar to family doctor, but the only difference for us, for our clinic, integrated care center, is that we don't see kids. So it's not exactly 100% same as family doctor.
Okay. Let's talk a little bit about inpatient care versus primary care, internal medicine, and clinic care. Can you help us understand how you divide that up, or how the what do you call it? Like, how do you share your time between those two?
Right. I think in the States, the word primary care physician is mainly outpatient kind of practice. And then I think in the States, they have what is called a hospitalist, who is an internist that see patient in the hospital.
Yes.
And then I think they're kind of communication between primary care and hospitalist. When I'm as a primary care doctor, send a patient to the hospital, I might call up a hospitalist saying, hey, one of my patients in the hospital, can you see them? And then there will be a transition. But for us in Thailand, what we do both, outpatient and inpatient. At Integrated Care Clinic, we work as a team, like a group practice. So we will take turns seeing inpatient. So like we have 3 doctors now, and we do like 2 weeks each. Like every 2 weeks we change.
Like a rotation.
Yeah. Right? So we will do a handoff, or, if I admit a patient from the clinic, then I will let one of our team that is on the rotation for inpatient know that, okay, I'm admitting this patient, and can you see them or take care of them while they're in the hospital? This kind of thing.
Because, for example, you guys, you're together all day long on some of those days as a team.
Exactly.
And doing some inpatient care and some clinic care. Is that correct?
Yeah.
For me, I saw 3 different doctors in my experience for my hip surgery here, but you probably were the doctor I saw the most.
Right.
Every day, I think twice a day. Was it twice a day?
Yeah, I mean, pretty much as an inpatient doctor at that time, I pretty much sit on the ward almost all day, just in case, any patient in the ward, they have any problem, I can be the one that the nurse come to.
And now that you told me that, it reminded me of that I saw you sitting out there at the nursing station, right? That I came back one time and you were sitting out there, and I was like, oh, perfect. So that's a good way to describe your day. What about any off-site kind of work or care? Do you have to work off-site sometimes?
Well, at the moment for Integrated Care Center, we don't have a satellite clinic, but Bangkok International Hospital is one of the hospitals in the network called BDMS network, and we do have more than 50 hospitals in network, like throughout the country, like rural areas in Chiang Mai, Hua Hin, Phuket. So I can't say that we don't have like offsite, but it's more like we are a network and we do referrals to each other.
So maybe it's not characterized. You don't need offsite.
No.
In a way, right? Because you already have the network.
Right. Sometimes like Dr.Paul has to fly to Chiang Mai to do surgery.
I saw him there.
Yeah.
So integrated health. You talked about referrals a little bit. Or can you explain a little bit about how the referral system works within the network? You
mean like from other hospitals?
Yes.
So basically, wherever you are in Thailand, when you get sick, you go to the nearest hospital you are. And, we have like our standard of practice. If it's something that certain hospital feel that is too much for them to handle, then they make a referral to the bigger hospital.
Okay.
Bangkok International Hospital or Bangkok headquarters is like super tertiary care level of hospital. So we pretty much are the hub of like everywhere make referral to us.
Right. For example, a sleep study. Is there a situation where one of the hospitals out in the provinces can't
Well, I think these
do
days
that service or provide
these
that?
days sleep lab is pretty like it's not hard to find, and I think almost like all of the big hospital or middle-sized hospital do have sleep lab. We can do that, but yes, our hospital, our sleep lab tend to be able to deal with more kind of complicated case.
You mean here?
Right.
This at this
Yeah.
at this
we
site.
do have like a sleep center that we have like a lot of specialists. You know, actually a lot of specialties can do sleep medicine, like me, internal medicine, neurologist, pulmonologist, like or ENT doctor.
Right.
So we do have a lot of specialties that practice sleep medicine here.
So that's a good point to bring up, is that interdisciplinary
Right.
sort of collaboration.
Correct.
I mean, do you have a weekly or a monthly kind of meeting for that, or it's just case by case?
Yeah, it's more like case by case. If we feel, for example, if I do a sleep study on a patient and I see, okay, you do have sleep apnea, and if that patient, no matter what I do, cannot tolerate CPAP, and I feel that, okay, you do have kind of structural issues that might be able to be corrected, I might refer them to an ENT doctor and like, hey, maybe you consider doing surgery on this guy because he can't use CPAP.
Count me in for that.
Yeah.
No. How about, AI, not AI, but technology these days? And is there some tools that patients can use that are part of the Bangkok International Hospital?
Yeah, well, we are developing, not developing, but I mean, we do have an app called BD, BEEDEE app, which is a telemedicine app. Patient can go online and, talk with a doctor or a pharmacist online. And then if we need to prescribe the medication, then it gets sent to the patient's house.
Wow. Nice. So this is a good example of the value proposition of getting your health care in Asia, and in here specifically at Bangkok International Hospital, where you have a doctor who basically intakes you, screens you, and then helps in that or advises in the decision making of what specialties you need, and then follows you through that whole process.
Exactly.
Right. Anyway, Dr. Jay, thank you for being on the podcast today.
Of course.
It's been a pleasure, and thank you for your time. Maybe we can do another episode on sleep studies in the future.
I'm happy to.
Good. Thank you.
Thank you, John.